Hey everybody, Dr. Viso here. In this video, we're going to talk about immunodeficiency syndromes, and the easiest way for me to kind of organize these is going to be to put these into categories like B and T cell variants, immunoglobulin variants, and then we're going to have some additional diseases that don't quite fit as neatly into these buckets. And there's a lot of different ways that you can organize this information. Again, we're going to focus on the high yield, and we're going to talk about what can we use from kind of the basics that we talked about before to distinguish some of these different diseases. We're going to start off with severe combined immunodeficiency. Now, this is probably one of the highest yield overall. When we're talking about SCID, or severe combined immunodeficiency, we're talking about involvement of both B and T cells. And so in your mind, when you're thinking about these different pathologies, you want to ask yourself, are there T cells involved and are there B cells involved? And if there's T cells involved, we know it's going to have some impact on cell-mediated immunity. Okay, because we need T cells, cytotoxic T cells, to destroy cells displaying antigens on MHC1. And when we're displaying an antigen on MHC1, a lot of times that's going to be a virus, right? An intracellular pathogen that's infecting that cell. And we talked about all of this in the last few videos, so I won't go through all the details on it here, but check out the last few videos. If you're a little confused by any of this, we go through all of the basics there. If I knock out my T cells, I'm going to knock out cell-mediated immunity. So things like viruses, for example, will actually favor this. Viruses are going to have a really easy time infecting our cells if we have poor cell-mediated immunity, right? If I knocked out my T cells, for example, because then I don't have cytotoxic T cells to then go and destroy cells that are displaying the virus antigens on MHC class 1. The other thing I need these T cells for is I need T cells and B cells to come together, right, so that I can generate class switching. Okay, so I can change the heavy chain on my immunoglobulins. Remember, most immunoglobulins are going to be IgM. But if I want to generate a memory response with immunoglobulins like IgG, for example, right? If I want to use IgG, I'm going to need to have class switching. Okay, so memory response can also be impacted if I knock out my T cells or my B cells, right? And the same concept is true when we talk about antibodies like IgA. I need IgM to class switch to IgA so that I can fight off things like certain parasites, right, that are going to be in the GI mucosa, where I'm going to have a lot of IgA. Things like Giardia, for example, are going to flourish in patients that have some problem producing IgA. And then, of course, we also talked about IgE being in this category. And in general, if I knock out my B cells altogether, I might also impact some of my humoral immunity just in general. So when I think about IgM, IgG, IgA, IgE, all of these might have some impact. I might have a pan-hypogammaglobulinemia. In other words, I might have a decrease in all of these immunoglobulins if I knock out my B cells altogether. And so the point of this is just from looking at this, right, you can kind of say, okay, look, I went through all of the physiology, I understand the mechanisms here, so all I have to do is figure out, okay, what's the problem? If I know what the problem is, right, if I knock out this T cell, well, guess what? I'm not going to have great cell-mediated immunity. I'm not going to have T helper-dependent antigens because I don't have B cells to bind to T cells with CD40 ligand because my T cells are knocked out, right? Even if I have functional B cells, that might be a problem with class switching and generating a good memory response. Because remember, not only do these B cells undergo class switching, but these B cells will also undergo affinity maturation as soon as they bind to these T cells and then get activated. And let's talk about some of these different pathologies. So again, going back to severe combined immunodeficiency, the thing that you want to know here is there's really a couple different, reasons that this disease comes across. And this is the big thing. When you're talking about step one, you got to know your pathophys. What's causing each of these diseases? So with severe combined immunodeficiency, the classic defect is in the interleukin-2 receptor. Now, this should make some sense to you, right? We talked about interleukin-2 in the cytokines video. You can go back and check that out. But the point there is that interleukin-2 receptor is very involved with growth of lymphocytes, right? It's very involved. You can even have autocrine signaling with interleukin-2. If you remember from that video, we talked about that. That's kind of the high yield thing to remember. You can have all different types of signaling, autocrine, paracrine, endocrine signaling from interleukin-2. And this allows proliferation of lymphocytes. So guess what? If this is defective, if those receptors are defective, I'm going to have a tough time mounting a strong immune response and generating the necessary T and potentially B cells. And this is the most common mutation that you'll see in SCID, and the classic inheritance pattern here is X-linked recessive. Now, you have to kind of juxtapose that to adenosine deaminase deficiency, which is autosomal recessive. And the difference here, the pathophys is completely different, right? Because interleukin-2 is responsible for T cell growth, right? So the interleukin-2 we talked about, this is primarily responsible for the growth of lymphocytes, right? So we're thinking lymphocyte growth. And so that's why if I knock it out, I'm going to have a very tough time mounting a strong immune response, or at least having lymphocytes that are going to be able to fight off my infections. Now, with adenosine deaminase deficiency, the difference here is that, remember what adenosine deaminase does. So let's just say I have some adenosine, okay, maybe some deoxyadenosine here. So these substances can get converted to hypoxanthine, okay, this is going back to your biochem, as well as uric acid by adenosine deaminase, right? ADA, I'll just put for adenosine deaminase. So adenosine deaminase converts these substances to hypoxanthine and uric acid. And the whole point of this is so that we can eventually just excrete these substances in the urine, right? Kind of as waste products. So these can just get excreted from the body, okay? So this is part of your purine metabolism, purine breakdown. Now the thing here is, if I don't have adenosine deaminase, for whatever reason, let's just say I don't have adenosine deaminase, now I'm gonna have a buildup of deoxyadenosine and I'll have a buildup of adenosine. So why is a buildup of this deoxyadenosine and adenosine a problem? Well, if we go kind of backtrack a little bit, so remember you have your ribonucleotide reductase, which essentially is going to take ribonucleotides and convert them to deoxynucleotides. The point of this is essentially we want to take our ribonucleotides that we might use for RNA, for example, and we can convert the sugar group so that we can use these structures in DNA. That's the point. So ribonucleotide reductase is going to generate deoxynucleotides. Now, deoxyadenosine is an example of a deoxynucleotide. So if I have a whole big buildup of this deoxyadenosine, for whatever reason, let's just say D-adenosine, right? If I have a whole bunch of this deoxyadenosine, what's going to happen is this is actually a product of ribonucleotide reductase. So it's going to have negative feedback on ribonucleotide reductase. Okay, and so this buildup of adenosine is going to inhibit the conversion of ribonucleotides to deoxynucleotides, which is a problem because then I can't use all of these ribonucleotides for DNA synthesis, right? I can't make deoxycytosine, I can't make deoxythymine, right? I can't make the other deoxynucleotides because I have this massive buildup of deoxyadenosine because I couldn't convert it because I don't have adenosine deaminase. And so we see a precipitous drop overall in the deoxynucleotides because of the buildup of deoxyadenosine. That's the point. If you think about lymphocytes in a newborn, for example, we're producing a lot of lymphocytes in that time period, and there's a lot of DNA that's required. And if I don't have the tools to make that DNA because I have low deoxynucleotides overall, right, then I'm not going to be able to make enough immune cells. And so adenosine deaminase is very classic for having a low B cell and T cell in the serum. Both of these are going to be extremely low in the setting of adenosine deaminase deficiency. Okay, so you can imagine if you knock out T cells and you knock out B cells because you can't make enough DNA to correctly make these cells, then there's going to be a whole host of problems, right? Everything under the sink, so to speak, is going to be involved. So that's adenosine deaminase deficiency. So completely different mechanisms, but they're both causing a similar variant in that we're affecting multiple cell lines and that we're affecting T cells and B cells potentially. That's the point here, that we can affect T cells and B cells. Now, the last thing on here is RAG mutations. I'm not going to go into too much detail on this, but remember we talked about what the RAG gene does. It's the recombinase gene that allows you to kind of shuffle some of the information in the cell so that we can produce different types of cells, right? All of that variation that we talked about. And we talked about this already in some detail. But again, these are the three classic causes. The two in particular to remember are going to be a defective interleukin-2 receptor, right? The lymphocyte growth receptor, and adenosine deaminase deficiency. Now, how does this present? Normally, in a lot of these different pathologies, we're going to have a normal newborn. Why is that? Because remember, the IgG antibodies can cross the placenta. So you can actually still have mom's antibodies as a newborn. And so you can still fight off some of the infections because of what you have from mom. But over time, what's going to happen is those antibodies have a half-life, and those are eventually going to start to come down. And so these children will often have failure to thrive, recurrent infections. Typically, this is going to be a younger patient, around 6 months to 12 months of age when this initially gets diagnosed. You can also see absent lymphoid tissue. Now, the point here is you want to be kind of sharp on, what in the lymphoid tissue is involved. Let's say I biopsy a lymph node. Okay, let's say I biopsy a lymph node and I tell you that, hey, this lymph node has little to no follicles or very small follicles or very small germinal centers, for example. What am I basically telling you? I'm telling you that the B cells are primarily involved, right? Because that's where the B cells are going to live. There's going to be dormant in primary follicles, active in some of the pale staining areas of the germinal centers, right? And so this would suggest potentially that B cells were probably involved, right? Now, on the other hand, if I told you that, hey, the paracortex is absent or hypertrophied, for example, a very small paracortex, we might be talking about T cells. This all goes back to the first video where we had to understand, where do the B cells come from? Where do the T cells come from? And so it's kind of integrating that information. So you can get this information. You can get them telling you that they biopsied a lymph node and there's, very small follicles, low paracortex, the absent lymphoid tissue. This is all very classic, pushing you in the direction of a B and T cell disorder. And conversely, you can have a normal paracortex with very small follicles. And in that situation, you might be thinking maybe this is more of an isolated B cell scenario. Okay, so we'll talk more about that. But again, I don't want to get too off track. So in terms of the diagnostics here, the big one to remember are these Tregs. And so the Treg stands for T cell receptor excision circles. And I'm not going to go into, all of the detail on this. This is one of those things I would just remember specifically for severe combined immunodeficiency, is that you can test for this using Tregs. And this is actually frequently done in the newborn screening. So they'll do, an assessment to look for SCID by trying to measure these T receptor excision circles. And they're going to tend to be very low. And part of that makes a lot of sense, right? You know that the T cell count is going to be low. And so this being some surrogate. The other thing you can classically see here is an absent thymic shadow. And this is not just something that you see in severe combined immunodeficiency. You can also see thymic hypoplasia or thymic aplasia in general when you're talking about DeGeorge syndrome, for example. Point here being, when you see absent lymphoid tissue, right, paracortex, follicles, right, you're also expecting your thymus, which we already said is part of the lymphoid tissue. It's where the T cells mature. That's going to probably be absent if I don't have T cells, right? And so if you did flow cytometry, you would see very low numbers of T cells. And we already kind of showed that flow cytometry graph kind of earlier in the series, where you can kind of have two lines going each way, and sometimes you'll see a bunch of dots on there representing certain cells. And so sometimes you'll see, a CD marker, it'll be CD, and then some number here that would represent that this CD marker is present in your flow cytometry sample. And then you'll have another one here, right? And so this one, you might see no dots here, or you might see dots up here, meaning that it has a combination of the two, for example. But the point is, you have to know these CD markers to understand these flow cytometry graphs. So for T cells, right, what's the classic CD marker that you want to be familiar with? You really want to be familiar with CD3. Okay, so CD3 is going to be pretty much on all of your T cells. So if I gave you one of these graphs, for example, right, and I said that, okay, this person's CD3 is here, maybe they only have a dot here or a dot here. They have very little CD3 detected in that sample. Well, that will tell you that the T cells are very low. That's something we would expect in severe combined immunodeficiency. You can also see extremely low levels of serum immunoglobulins of all isotypes. And the point here is remember, if I don't have functional B cells, or I don't have T cells that can allow activation of those B cells to undergo class switching, in those situations, I'm going to have low IgG, IgA, and IgE. And because, especially in adenosine deaminase deficiency, right, we're not going to have any B cells either. And so I'm not even going to get IgM. So all of these are going to be knocked out. So all of my immunoglobulins, all isotypes are going to be low. Let's say that you had a newborn and you're testing your immunoglobulins after the first couple days of life. Well, sure, you would expect the IgG levels to be relatively normal at that point, because remember, you still have mom's antibodies. But if we're talking 7 or 8 months out, then in a patient that has SCID, you would expect the serum immunoglobulins generally to be very low.